Hello, I'm Alexia, and let me help you to take the fear out of birth with a mix of real-life positive birth stories and birthing experts sharing their wisdom. I'll also be sharing techniques for getting into the fearless birthing mindset. And join the Fearless Momship community for bonus podcast episodes, access to free birth preparation downloads, and loads more stuff to help you to prepare for a positive birth. Join today at fearfreechildbirth.com. Hello and welcome back to the Fear Free Childbirth podcast. This is me, your host, Alexia Leachman, and thank you so much for joining me today. Now, on today's show, this is a really, really important episode. I'm going to be talking about optimal cord clamping. Today on the show, I'm going to be chatting to Amanda Burleigh. Now, Amanda Burleigh is a UK midwife, and she has been campaigning for optimal cord clamping, or her campaign, which is known as Wait for White, to make sure that we do not cut the cord earlier than is necessary. Now, there's loads of information and research about this, and there's really solid evidence as to why you should be not cutting the cord straight away. Unfortunately, many midwives worldwide still don't know this, and this is a practice that is continuing. And once you find out why you should not be cutting the cord straight away, you will absolutely be wanting to insist with your healthcare team not to do it. So today's chat is really to help you to better understand why you need to wait for white and wait for the cord to have all the blood transferred from the placenta to the baby before you cut the cord. Now, you need to wait up to 4 to 5 minutes in an ideal world. But in today's chat, Amanda's going to share with you exactly why you need to wait that long, if you need to cut it sooner, how soon you can bring that forward to, what other considerations you need to take into account. So it's quite a meaty episode, but you know what? It's really inspiring. It's really informing, but also one thing that really comes across really strongly in this is the only way that we can bring about change among the healthcare professionals is for us as parents-to-be, as mothers, as pregnant women, to demand that they listen to our requests around cord clamping, because some hospitals are still dragging their feet on this. And this is a real health issue. This is something that you are really going to want to take into account for your baby's long-term health. So listen up. You might want to make notes. The podcast show notes does include references. She does talk to a lot about research and some of the evidence that's out there. So I do include references within the podcast show notes. So are you ready? Are you ready to listen to Amanda Burleigh talking all about optimal cord clamping? Now, before I do hand over, I just want to say the sound quality on today's episode isn't brilliant because we had a bit of a bad line, me and Amanda, but we'd been trying to put a chat in for at least 6 months. And so I didn't want to risk not running this chat because it is so important. And otherwise it would have been another 6 months at least before I got to speak to her. And also my microphone didn't come on. So you've got me listening like a very faint microphone in the background. So, but park all that because the information that she shares is utter gold. Okay, over to the chat. Well, hello, Amanda, and welcome to the Fear Free Childbirth podcast. Thank you for joining me today.
It's my pleasure, Alexia. Thank you for inviting me.
Now, Amanda, you are a midwife, but please, and we're going to talk about some really great stuff, specifically cord clamping, which I know a lot of expectant mums need to hear more about. But before we go into all that, can you just tell us a little bit more about who you are?
I've been a midwife for 28 years. Before that, I was a registered nurse, and I've worked in all the clinical areas in midwifery. About 10 years ago, I realised that we were practising immediate cord clamping, which wasn't evidence-based practice, and since then I've been setting about changing that practice.
So what is it that first alerted you to the cord clamping thing then? What is it that kind of sparked your interest or your curiosity into that as to why it needed to be changed?
I've been practising as a midwife for 16 years. And I'm actually a mother of 2 boys who are now 22 and 19. Both of them have attention deficit disorder, and I'm not saying that immediate cord clamping causes attention deficit disorder at all. It runs in the family. What that did is put me in contact with school teachers and other caregivers who expressed their concern that so many children have behavioural problems, learning problems, and other difficulties, diabetes, asthma, allergies. I'd also noticed the same with my work colleagues. There were 6 job shares. We shared 3 jobs between us. We had 14 children, 8 boys, and 6 of them had learning problems, and only one of those could be attributed to a chromosomal defect. So I started looking at different things to see if there was a common denominator. And that included looking at coffee, whether it was caffeine or alcohol, whether it's cigarettes or whether it was sugar, or whether it was just simple things that we were doing at work, as in Hibby scrub that we used for scrubbing up for theatres. And I couldn't find anything, but I'd looked over a long time. I extended that to looking at lead in water, fertiliser in the fields around us. I did notice that it was mainly boys, and it did affect a lot of my friends' children as well. And then one night I just suddenly had a brainwave because I reflected on our own practice as midwives and realised that we'd been taught to clamp and cut the cord immediately. And I began to wonder if there was any evidence behind that. When I got onto the internet and tried to examine the evidence, it became very quickly apparent that there wasn't any evidence to support immediate cord clamping at all. It was just something that we'd done and continued to do, and there's never been any evidence, and there still isn't any evidence to support immediate cord clamping. Immediate cord clamping deprives the baby of 30% of the blood volume. It was introduced to when oxytocin drugs came into, which were administered to the mother to prevent postpartum hemorrhage and reduce maternal mortality, which did work, but at the time nobody had ever considered the effect on the baby, and to this day they still, well, until 16 years ago they hadn't thought about the effect on the baby.
So there's no evidence at all to support immediate cord clamping. Is there any, do we know why this was started at all? Like, is there any reason why this was, other than the oxytocin drug, is there anything else that you know that why we're doing this?
Third stage of labour for the mother is considered the most dangerous, because obviously that's the time that they can bleed, they can have the hemorrhage. And at 50, 60 years ago, women were dying of postpartum hemorrhage, particularly in the home, because of the lack of medical attention. And the oxytocin drug shuts down the placenta, it makes the uterus contract, which shuts down the placenta and shortens the third stage of labour. So it seemed like a really good idea at the time. But even in the books, it was documented that the baby lost a third of their blood. And because babies were delivered, they cried. It didn't seem to have it didn't seem to be a noticeable effect on the child, and that's why it's gone on for such a long time. I think the accumulation, because of course now we're actually clamping and cutting the cords of mums who had their cords clamped and cut. Maybe there's an accumulative effect which isn't evidence based, but looking at the problems that we have globally at the moment, they're blamed on other things, environmental factors. But looking at the whole picture, this could play a part as well. Recent research is showing that immediate cord clamping does cause iron deficiency anemia, and 4-year studies of the same children have shown that the male children have decreased fine motor and social skills, which is extremely significant because that impacts on public health, it impacts on child mental health. There are big studies now going on. There's a big one going on in Nepal by Ulla Anderson, and talk about it was his research that I've just quoted, to see the long-term effects of immediate cord clamping.
So for a mum who's pregnant, who's thinking about writing a birth plan and wants to put a note in her birth plan around this, what are the things that she needs to kind of bear in mind or specifically write out on her birth plan so that her wish, so that, you know, she's doing the best she can for her baby based on some of the things that you've mentioned?
In 2005, when I first identified this, along with quite a few other people, but I seem to have been a bit of the loudest, all the guidelines actually stated that immediate cord clamping should be done. And all the guidelines now have changed. World Health Organisation, then the Royal College of Obstetricians and Gynecologists, Royal College of Midwives, and now NICE recommend delayed cord clamping for at least a minute. The problem we have is that practice is sketchy, and some hospitals are well on board. The hospital where I work is very on board with delayed cord clamping, even at caesarean sections. But you have also other hospitals that haven't really looked at their guidance or practice and don't think it's significant. So it's important for all parents to be well versed in delayed cord clamping and the benefits. And what I would say to parents is look at the evidence. Really, it's not rocket science. You know, it's very easy to take on board that when the baby's born, that the cord should be left to complete its job. Anything before that is intervening. It's an intervention that really needs consent from the parents and informed choice and consent from the parents. So any parent needs to write in their birth plan that they would like delayed cord clamping. NICE recommend 1 minute to 5 minutes. I think in the absence of complications, the cord should be left until it's finished its job, which is a campaign that we're doing, which is called Wait for White. The cord, when the baby's first born, is full of blood, and the blood is transferred to the baby. So the baby and the placenta are full of their one circuit. And when the baby's delivered and using their own lungs, the transfusion to the baby is finely tuned. And when the baby's out crying, pink, and has transited to outer uterine life, the cord will finish pulsating and become white. And theoretically, you could cut through the cord without actually clamping it, but I wouldn't recommend that. But it's just that it's finished the process. And if you think from conception to birth is a miracle, anything that intervenes before that process is finished is an intervention. And unless the caregiver thinks that's necessary for resuscitation, for example, the cord should be left alone. And I would ask the mother to ensure that the father knows, not the father, the birth partner, knows as well, and has instructions. Because in some cases I've had in the past, or I've heard that the cord can be clamped unless the person that's with the mother intervenes. Their wishes can be ignored. A father once put his hands over the cord to stop the midwife actually cutting and clamping the cord, and then 3 years later they delivered a baby at the same hospital, and they were doing delayed cord clamping. So we're in a time of change. It will come, but because we don't know how many people are delaying cord clamping, which hospitals are delaying and which aren't, every parent needs to know about this.
And so you're speaking about some hospitals that still aren't, and I'm assuming that you're meaning the UK. I'm just wondering, on a global perspective, whether, for example, in the US, for example, or in Australia or Canada, this campaign has reached them, and whether this is a global thing that's being recognised.
It is a global thing. We're all fighting for the same cause, and I'm part of a global network. I think the UK are leading the way, really, because we do have guidelines now that actually state that the cord should be left for at least a minute. Other countries are well up on this. Norway and Sweden, they have some very active people over there. Australia have very active midwives, but the guidelines actually still state immediate cord clamping. So unless you go to a place where they are practicing delayed cord clamping, you are more likely in America and Australia to get immediate cord clamping.
Right. Okay.
So everybody needs to know about this, and there's a global movement. We all work together to try and get this changed, but it is very, very difficult. I've been working at this for 11 years, and trying to implement change is very, very difficult. And we're getting there, but we're not quite there, and we're a lot further on than a lot of countries. Particularly, the Australian midwives have a big fight on their hands.
So, in order to bring about the change, I guess one of the best ways we can do that is really to empower parents with the knowledge and the information so that they can demand that from their midwives.
Parents are actually the biggest change agents. And when I first identified this, I went to all the managers and the doctors and said about it, and they said, well, it's not particularly important, and you need evidence to change practice. I was told that I had an interesting theory that had no scientific evidence to back it up. And when I said, well, actually, you could turn that around and say that what we're doing actually has no evidence to back it up, it was very difficult, because people I think the most dangerous phrase is that we've always done it that way. Why change? We've always done it that way. And trying to get people to change, particularly when the babies have been crying and they come out and use the lungs. And some people actually thought that the babies had to have the cord cut so that the lungs would work, which is completely bonkers. I went to all the managers and asked them to change, and it became quickly apparent that this wasn't going to work. So I went to work as a community midwife and began empowering parents. And even though I got sick of the sound of my own voice, I still continued to give one-to-one informed choice to all parents. And it was actually the parents demanding this for their children that have been the biggest change agents. And the RCM actually acknowledged parents' role in changing it, because it's demand. And all parents want what's best for their children. All parents also expect that caregivers are going to do the best for their children, and are quite shocked that when they find that we're actually doing something that is where they're not getting informed choice, and it's an intervention, and they're not given informed consent. So it is quite tricky ground.
So the Wait for White campaign, and that's a really easy thing to remember, and certainly I'm just wondering whether, you say it's a minimum of 1 minute that's recommended, but it could be up to 5 minutes, and so waiting for white is really probably the best way of judging the time that we need to leave the cord alone. Is that fair to say?
It is. Diane Farrow did some research in 2010, as far back as 2010. She's from Bradford, and it shows that if you leave the cord intact on the babies gain up to 214 grams, which is nearly 7 ounces. They did some more research that showed that most of the placental transfusion is over by 2.5 minutes. So even, and quite a lot of that transfusion is over by 1 minute. It's not completed, but even if your baby, if the baby needs resuscitating, the baby should be getting at least 1 minute before the cord's cut. The transfusion continues over, like I say, the transition from intrauterine to outer-uterine life is fine. I feel is finely tuned. So the placenta and the baby are working together for that baby to become used to life outside, breathing, pink, crying vigorously, and then the cord will shut down. In most of the cases, the cord completes pulsation by about 5 minutes. Sometimes it can be longer, and even up to an hour. But when the baby's crying and it's vigorous and it's pink, if the cord was still pulsating, I think by then, there's no harm to be done by clamping and cutting the cord, and that is in rare incidences. Most of them finish the job after about 5 minutes.
So is there anything else around cord clamping that parents need to know that they probably don't know that you'd like to share?
There's 2 different ways of managing the 3rd stage of labour, which is why the oxytocin drug came in. One is active management of the 3rd stage, where the mother is offered an oxytocic drug, which will help shut down the placenta. It helps shut down the placenta and shorten the 3rd stage of labour, and is recommended. We are moving from active management of the 3rd stage to physiological 3rd stage management of the 3rd stage, where the placenta is allowed to deliver on its own without any intervention, without any oxytocic drugs. Practice, well, certainly in my practice for the first 16 years, I never saw a physiological 3rd stage of labour. But they are becoming more common, and the RCM recommends that midwives become competent in active management of the 3rd stage with the oxytocic drug, and physiological, where you leave it. Oxytocic drugs are very important with women who are at risk, so they've, for example, they've got a twin delivery or a large baby, or they've had a long labour, because there's an increase in the risk of having a postpartum hemorrhage. Any woman who has active management or physiological management can have delayed cord clamping. The oxytocic drug, NICE recommend that the oxytocic drug is given immediately after delivery, and then the placenta is delivered. The cord is clamped within 1 to 5 minutes. Some midwives will actually delay the oxytocic drug for a few minutes, and then leave it a couple of minutes. It takes 2 to 3 minutes to transfer to the baby, and then we'll clamp and cut. NICE say that it doesn't matter when the oxytocic drug is given, you can give it immediately and then clamp and cut for 5 minutes, whereas New Zealand actually states that they prefer that the cord is clamped and cut before the oxytocic is given, because we haven't actually got any evidence to say that the transfers to the baby doesn't cause any harm. I think that the risk is very small, and NICE obviously back that one up. But I think that if you give an oxytocic drug, it causes a contraction of the uterus, which is really quite powerful, and I think that it upsets the transition between the placenta and the baby. So if there's low risk and there's no risk, my personal practice is to delay giving the oxytocic drug until the cord has stopped pulsating, and then to give the injection, clamp and cut, and then deliver the placenta. So there are variations in practice. Bath midwifery unit actually delay cord clamping, delay giving the oxytocic drug until after the cord has stopped pulsating, and they've realised that their physiological 3rd stage has gone up considerably, because the placenta, if the cord has stopped pulsating, the placenta is already on its way. And the research also states that giving the oxytocic drug, it doesn't matter when the timing is, it doesn't affect the incidence of the postpartum hemorrhage, so it is safe to delay.
So basically, once you've had your baby, you've waited for the cord to do its job, it's gone white, then the cord can be clamped and cut, and then if the placenta isn't making any sign like it's coming out, or you want to maybe speed that section up, then you can have the injection that will start bringing the placenta out. And so that would be the order for a mum to do it, if that's what you wanted to do.
It's a tricky situation, because there's so many variations in practice, and your midwife is practicing what they feel is right. Personally, NICE say that you can have the injection and have the injection immediately and clamp and cut between 1 and 5 minutes, which is fine. I personally would deliver the baby, put the baby skin to skin, make sure that they're crying, leave the cord intact, then go and wash my hands or whatever. After a couple of minutes, if the mother wants active management, give the injection, wait a couple of minutes for the cord to clamp and cut the cord. by then you've usually got 5 minutes of 5 minutes time have gone anyway, and the baby's, you know, that baby's got the full transfusion. They're crying vigorously, they're nice and pink, they're skin to skin, and usually by then they can't stop pulsating anyway. So it's you know, it's individual practice based on a holistic experience. At the time, the midwife is looking at the mother and looking at the baby, so there's little variations in practice. If you know, if the baby's delivered and you think that the mother's at risk of bleeding, you might want to give the injection a little bit earlier. It's about talking to the parents about what they want as well. If there's no risk, baby's skin to skin, you might want to hold off for a bit longer. It's about informed choice.
And is it worth then mothers talking to their midwife, their community midwives, in advance of the birth to sort of understand what their midwife's perspectives are on this, to try and get a better understanding? Is that something that's worth doing?
It's certainly worth doing. Parents should be getting informed consent or information about that antenatally. Unfortunately, at the moment, a lot of hospitals are still doing immediate cord clamping. They can ask their midwife, but again, because of change, a lot of midwives will understand the physiology around this. Some may just say, we'll see what happens when you go to the hospital. But I would recommend that all parents become au fait in this and read up the research themselves and look at the websites. And see what the hospitals are doing or what people recommend, and it's becoming more common now. There was an article in the Mail a couple of weeks ago because I do get parents writing to me to say that they've had their wishes ignored, or hospitals say that maybe they get too jaundiced or they get polycythemia if the cord's left. This is not backed up by evidence. You know, there's no evidence to suggest that. It's just obstacles that are put in the way of change. We're in a strange transition and people resist, and we are coming through that, but that's why parents need to know and do their own research.
And is there anything that parents can do? I mean, you know, heaven forbid that they put that in their desires and wishes and it's ignored. Is there anything that parents can do post-birth to try and give back to the baby what the baby might have missed out on? Or is it too late if they've not done that?
Too late.
Is it?
It is too late, really. I mean, like I said before, most babies are absolutely fine. You know, obviously we would have picked up on this a lot quicker than 60 years if we were causing huge damage. But and the other thing is some babies need resuscitation. You know, we have, if a baby comes out and they're not breathing, you have to choose between giving them delayed cord clamping or resuscitation. Resuscitation must come first. Saying that, we realised in 2010 that one of the obstacles would be the choice between delayed cord clamping and resuscitating the baby. And along with a group of consultants, we devised a trolley, a resuscitation trolley, which is a small resuscitation trolley that can go bedside, so that the baby actually gets both, that the baby can be resuscitated with the cord intact. And some hospitals are using those really effectively. There's been a big study in San Diego where a consultant down there said that they've helped save babies' lives with this trolley. The thing with delayed cord clamping is the babies that benefit most from delayed cord clamping or optimal cord clamping are the premature babies or the compromised babies. Premature babies, a midwife called Judith Mercer in the United States has done loads of research, and it shows that premature babies have decreased blood transfusion, intraventricular hemorrhage, necrotizing colitis, cerebral palsy, anemia from having delayed or optimal cord clamping. There's lots and lots of studies that identify the benefits of FEM babies. Unfortunately, because of the resuscitation, because they're the babies that most likely need resuscitating, they are the babies that are most likely to get immediate cord clamping. So we are trying to move away from immediate cord, having that choice. Whereas if you use a bedside resuscitator, the baby can get at least a minute or 2 minutes of both delayed cord clamping whilst the initial resuscitation is going on.
So basically, the challenge around resuscitation and cord clamping is a physical one, by enabling the baby to be resuscitated in a manner that keeps the baby close to mother. It's not anything else. It's just a physical, practical thing.
It is, because what happens at the moment if people haven't got the basics of the lifestyle trolley is that they clamp and cut immediately to take the baby to a resuscitator. Ideally, the baby should be assessed at the bedside. You know, you spend the first 30 seconds examining the baby and assessing the baby, followed by 5 rescue breaths. which could mean that the baby would get at least 30 seconds of delayed cord clamping, which again is it's quite a substantial transfusion before the baby is just then transferred to the big resuscitaires. But what happens now is they anticipate a baby needs resuscitating and they clamp and cut immediately to take the baby over. People need to be aware that just delaying for 30 seconds makes a phenomenal difference to the babies.
And I've heard about cord donation, but I don't fully understand that too much. Would you mind telling me a little bit more about what cord donation is?
Cord blood donation, there's companies in the UK who, well, across the world actually, it's really, really big business, who want the stem cells from the umbilical cord. Because we've been doing immediate cord clamping for such a long time, and guidance from NICE has only changed in 2014, they advertise for the stem cells and they said that it's a waste product, which in the past is true. It has been a waste product, but we now know that the baby needs that blood and it's not a waste product. So they advertise that they would like the baby's stem cells and that they, a typical advertisement from one of the companies would say, save life, give life twice in one day. Your baby's umbilical cord cells could save somebody's life. And they encourage parents to donate their baby's blood. I said before, immediate cord clamping deprives the baby of approximately 30% of their intended blood volume, which consists of, well, we're not quite sure exactly what it consists of, but we do know that it consists of millions of stem cells, red blood cells, white blood cells, and goodness knows what else. The cord blood companies want the hands on the blood so that they can use it for research or match for somebody else. You know, you get advertisements for children who want life-saving stem cells. What parents don't realise is that they're actually signing up to give this blood because it's an altruistic offer of giving the baby's blood to save somebody's life or for research. But what they don't realise is actually that they're giving away up to 30% of the baby's blood volume. And because of the research that's coming out now that's showing that particularly male babies at the age of 4 have immediate cord clamping, have got decreased fine motor and social skills, and we do not know what the long-term effects is. Parents that are donating the cord blood are not getting fully informed choice.
So basically what you're saying is when they sign up to that, they're giving away blood that actually would be much better in their own child, and they're depriving their own child of something, and they really shouldn't be signing up for those kind of schemes.
Yes.
Okay.
A lot of the companies say that you can store your own baby's own stem cells in case they could become poorly in later life. My argument is that if the baby's actually got the stem cells inside them, they're much less likely to be unwell later on in life. There are companies in the UK that do both. If somebody wants to do delayed cord clamping or even optimal cord clamping, which is a wait for white, there are companies who are happy to do that and take what blood is left in the placenta. And I go through my website if anybody asks me about that. So you can do both. If you want to do both, you can. Okay. But clearly, immediate cord clamping or clamping after a minute is not advisable. The baby needs at least 2 minutes. Yeah. I know in Australia where they haven't got the guidance to say 1 minute, babies are getting immediate cord clamping there, and our parents are giving away at least 30% of the baby's blood volume without actually getting the informed. If they were given informed choice and all the information, I don't think they would be signing up to it.
Well, this is a fascinating topic that I think, and certainly I wasn't very clear on a lot of the detail that you shared today. When I was pregnant, my little one turns 2 in a short while. So this is, it just shows that there's a lot more for parents to learn, and it is all so new. You're right, in a big period of change. Is there anything else before we go that you think needs to be said that parents need to know about this that we haven't talked about yet?
Because we don't want to be scaremongering, nice guidance say that all babies should get at least 1 minute, unless the heart rate is going really, really slowly, and then of course resuscitation comes in. But it does mean that most babies should be getting delayed cord clamping, particularly if the lifestyle trolley comes in. And I have to say that I have no financial interest in that whatsoever, because it's so important. And a lot of mums are having caesarean sections, elective caesarean sections. It is perfectly acceptable for a baby to have delayed cord clamping with caesarean sections. A lot of hospitals are dragging their feet because of fear and because of obviously the worry in that period when the baby comes out. If you think that the placenta is actually transferring oxygen to the baby whilst it's intact, that's a resuscitative measure in itself. But I advise a lot of parents to look at the research, take the research in. Judith Mercer does a fantastic article called Rethinking Placental Transfusion. If parents can get their hands on that, take it into the hospital and give it to the doctors. It's like everything you needed to know about delayed cord clamping. the parents are actually changing practice in that hospital, because if they insist that they have delayed cord clamping at cesarean section, and you've got a team of people in the theatre who sit there and watch this baby deliver the baby, put the baby onto the woman's legs, and watch this baby transit from intrauterine to extrauterine life and pink up, they can quite often change practice for all those doctors or people that are in the room.
Is there a petition that they can sign as well to sort of come together collectively and make a big noise? You're very active and you're a campaigner for this. Is there any way that you would like parents to support you? What could they do to help you and your cause, to help you bring about change even quicker than you already are?
I did do a petition in 2011, I think, because NICE said that they wouldn't consider changing the guidance earlier, and I did get 5,500 people to sign a petition from over 44 different countries. And that was to ask NICE to up their guidance. The fact that NICE has upped their guidance means that other other countries will be looking at the NICE guidance and will be following suit. So it's tell your friends in different countries, pointing them to the evidence. And I worked as a community midwife, I worked in an area where we had a lot of women from Eastern European, and they transferred their knowledge to people in Eastern European areas. I've worked in Africa, South Africa, Kenya, and South Africa. And South Africa, we exported bad practice, because we exported management of the third stage of labour, but we also exported immediate cord clamping. And going out there and training the midwives who work in dreadful circumstances. There might be one midwife in a home or a hospital that if a baby comes out, to leave the cord intact, because in effect they were doing immediate cord clamping because that's how they'd been trained. And they were actually cutting off their body. The placentas will resuscitate the baby. In most cases, the baby will be resuscitated by the placenta. And the first thing they were doing when the baby was born was clamping and cutting the cord. So in effect, they were cutting off their body. Like I say, it's not rocket science. It's just practice that's been handed down that people have just done because they've been taught it. And really looking at it, reflecting on your practice. This isn't rocket science, and it needs to change globally, worldwide, because of the damage that we've done. We may look back in years to come and think, what on earth were we thinking about? Well, I'm sure we will. I think that anyway.
Amanda, thank you so much for sharing all this on a matter that's clearly very, very dear to your heart. Thank you once again for joining me on the Fear-Free Childbirth podcast. Now, is there any links that you'd like to direct people to, maybe your website or anything where you think that would be worth them going to, your Facebook page or anything like that you'd like to share with you?
We've got the Facebook page, which is Optimal Cord Clamping Wait for White. There's a student midwife called Hannah Tizard who was absolutely fantastic, and she developed some stickers to go on the notes that give informed. Well, it gives the evidence. They give the evidence, and you can put those on your non-negotiable notes to say that you request optimal delayed cord clamping for at least 5 minutes. She's done fantastic work, which has also been recognised by NICE, and she has a website which is www.bloodtobaby.com. So that's blood to baby as in one word, where the resources, you can get resources. It's more of an educational tool as well, because she gives the information, but anywhere in the world can apply for these resources, and they can be shipped out free of charge. So people to have a look at that website and spread the word globally.
Absolutely. Well, thank you once again for joining me on the Fear-Free Childbirth podcast, Amanda. Thank you very much.
It's my pleasure, Alexia. Thanks ever so much for inviting me.
You've just been listening to me, Alexia Leachman, here on the Fear-Free Childbirth podcast. Thank you so much for tuning in. Now, this is just a wee reminder that if you'd like to listen to bonus podcast episodes and have access to loads of birth preparation downloads, my video mini-series on reducing your fears and so much more, then join the Fearless Mammoship community today. You can join at fearfreechildbirth.com. Until next time, bye for now.